Good afternoon. According to Judith Stanley, atrial fib is the most common arrhythmia found in older adults greater than 65 years of age. That places them at a higher risk for stroke, CHF, and mortality. The title of our lesson today will be Atrial Fibrillation, Rhythm Control versus Rate Control in CHF, Stroke, and Mortality. The purpose of this study is to answer the question in persons over the age of 65 with persistent atrial fibrillation, do pharmacological rhythm control agents offer a lower risk of stroke, CHF, and mortality when compared to pharmacological rate control agents? In other words, if you control the rhythm, are the outcomes better than if you control the rate in CHF, stroke, and mortality? The pathophysiology of atrial fib. In Heather Greenberg's article, she points out that atrial fib is supraventricular tachycardia characterized by multiple rapid re-entry impulses that cause the heart to have inadequate contractions, which damages the atria and firing nodes, making the heart fire rapidly and irregularly, and then decreases the emptying of the heart. When you decrease the emptying of the heart, it pools the blood, it coagulates, and it can break off clots that travel to the brain, causing stroke, or it can pull backwards into the lungs, causing congestive heart failure. What does that mean? That means that the heart beats irregularly, rapidly, and does not empty when it pumps. You get clots that form in the heart and break off to cause the strokes and the CHF, and ultimately death can occur. The risk factors identified for developing atrial fib are valvular heart disease, hypertension, dilated cardiomyopathy, which means an enlarged muscle of the heart, coronary artery disease, meaning the arteries that are inside the heart that feed the muscle, or aortic stenosis. The symptoms of atrial fib are hemodynamic compromise, which can be a rapid heart rate, irregular with lower inadequate blood pressure, shortness of breath, palpitations, or syncope. In my article review, there were 5 trials that were compared, many of them mentioned across several of the articles. The PIAF or PIAF trial enrolled 252 German patients with persistent atrial fib people greater than 65 years of age. Amiodarone was the drug of choice for restoring the sinus rhythm. To control the rate, diltiazem was the drug of choice. The study concluded that there was no significant difference in the quality of life between the two groups. The STAFF trial was 200 German patients, and these patients all had atrial fib. Judith Stanley does not list the medications that were used, but did conclude that although there was no difference in the quality of life, the rhythm control patients required more frequent hospitalization. The RACE trial enrolled 522 Dutch patients. All patients received anticoagulation therapy to prevent the clotting of the blood that pooled in the heart. The rhythm control patients could stop the anticoagulation medication after 1 month of being in sinus rhythm. Thromboembolic complications were more frequent in the rhythm control group, especially after stopping the anticoagulation therapy. Less than 40% of the rhythm control patients remained in atrial fib or remained in sinus rhythm at the completion of the study. The Hot Cafe study was 205 Polish patients with persistent atrial fibrillation. No difference was noted in the rate or the rhythm control group. However, the patients who achieved sinus rhythm for 4 weeks were able to stop the anticoagulation therapy. The AFFIRM study was the study that was most mentioned in each article. According to Johnson, McCabe, and Marcus, no difference was demonstrated between rate or rhythm control strategies for patients with atrial fibrillation. Beta blockers were used in this study. Now we will discuss the rate control agents. Beta blockers commonly used to control. Beta blockers are the most common medication used to control rate. They're antidysrhythmic agents, and the most common one used is metoprolol, also known as Lopressor. They block the beta-1 adrenergic receptors by decreasing the sinus node discharge and suppressing the transmission of atrial impulses in the AV node, and that decreases the heart rate. By decreasing the heart rate, you get better contractility in the heart, which means the heart pumps harder and the blood flows more freely. By having the heart pump harder, the blood does not pool in the heart, it empties the heart, and you don't get as many clots causing the strokes. The adverse reactions to Lopressor can be low blood pressure. They also mask the symptoms of hypoglycemia in the diabetic patient. Bradycardia is also an adverse effect, and so is hypotension. The patient needs to be taught to check their pulse daily and regularly to make sure that their heartbeat in their pulse is not only regular, but also greater than or at least 60 beats per minute. Hypotension, the patient needs to be taught the signs and symptoms of low blood pressure, which means that when they stand, if they get dizzy, they should stand slowly and go from lying to sitting, sit for a while, and then stand, waiting a moment before they take that first step. Calcium channel blockers. The most common calcium channel blocker is diltiazem and verapamil. Their mechanism of action is that they inhibit the calcium influx into the cell and decrease the heart rate. The adverse reactions of the calcium channel blockers is that they can increase the plasma levels of digoxin, putting the patient at risk for digoxin toxicity. Patients need to be educated that they should look for bradycardia, weight gain, and peripheral edema. Cardiac glycosides. The most commonly used cardiac glycoside is digoxin. Its mechanism of action is that it's a positive inotrope in the heart, increasing ventricular contractility, which increases the pumping mechanism of the heart. It makes it beat stronger and empty better. The common adverse reactions of digoxin are low heart rate and low blood pressure. Patients need to be educated that they should have their labs drawn frequently to make sure that their level of digoxin is not toxic. They should also be educated about signs and symptoms of digoxin toxicity. Those are bradycardia, weight gain, peripheral edema. Rhythm control and rhythm control agents. Antiarrhythmics. The most common antiarrhythmic is amiodarone for long term. It works on the heart by delaying repolarization and delaying action potential with effects similar to potassium channel blockers. It blocks the sodium, calcium, and beta receptors to decrease the SA node and reduces contractility in the AV node. Patients on amiodarone need to have a baseline chest X-ray obtained and pulmonary function test. Amiodarone has a significant drug interaction, especially with other antiarrhythmic agents such as digoxin, verapamil, diltiazem, quinidine, and the statins. The most frequent adverse reaction is low heart rate and low blood pressure. Anticoagulation. The most common coagulation therapy is warfarin or Coumadin. It's a vitamin K antagonist that has been shown to reduce the risk of stroke, but has increased the risk of hemorrhage. It has interactions with many foods and requires frequent monitoring, causing decreasing patient compliance and increasing discontinuation. The biggest adverse effect with warfarin is hemorrhage. Patients should be educated the foods to eat that are not contraindicated to the warfarin, those foods with high in vitamin D, such as leafy green vegetables, and those foods high in vitamin K are the foods that they should avoid. They should schedule a time of administration that is the same time every day, and their blood levels should be checked to make sure that they have a therapeutic international normalized ratio. The conclusion to the research critique that I was able to do is that atrial fib is the most common arrhythmia found in older adults that places them at high risk for stroke, congestive heart failure, and mortality. Early diagnosis and early treatment can help to avoid the adverse effects of the atrial fibrillation. In all of the studies, the conclusion is that whether you control the rate or the rhythm, the most important piece of the treatment is anticoagulation. If you can decrease the clotting, you can decrease the stroke. If you can increase the contractility of the heart and decrease the rate, you can improve the emptying of the heart and thereby help prevent the adverse effects of the atrial fib. Patients who are at high risk for developing atrial fib should be monitored closely, given education regarding when to contact a medical provider for signs and symptoms of deterioration. To answer the question, is rate control better than rhythm control in outcomes of CHS, stroke, and mortality? I would conclude through the article research that I did that rate control, although better, probably is not significantly better in terms of rhythm control, but either rate control or rhythm control with anticoagulation seems to be have the best outcomes. Thank you.